Good morning, everybody from Australia, and hello to everyone else in the world. Teaching the 3 R's of seizure first aid. My name is Melissa, and I will be moderating today's session on the 3 R's of seizure first aid. Housekeeping, all lines are muted during the presentation. Please write questions in the Q&A box. Please direct any technical questions to the Q&A, and all of the ILAE Nursing Section webinars are recorded and located on YouTube. So search ILAE Nursing Section webinars, and a special thank you to all of today's presenters. So membership, 880 across 6 regions, as kind of depicted here on the screen. I'll just leave that there for a few seconds for people to kind of appreciate. And just to increase those numbers, if you could please join us, joining the ILAE Nursing Section via this QR code, or later on I'll put up a website as well. So today's session, the 3 R's, so recognition, response, and recovery, are the 3 R's of seizure first aid and are used as a framework to prevent injury, promote brain health in people suffering from seizures. In today's webinar, we will be highlighting the importance of seizure first aid and why it is an essential skill for all people and in hospitals and community care for nurses to be able to teach nurses about seizures first aid. Each of the speakers today will speak to their experience in teaching seizure first aid and impart upon what we're trying to ensure that everybody out there is able to provide basic seizure first aid. So the who, the what, the where, the when, the how, and the why. The objectives of today's webinar is to highlight common and essential approaches to seizure first aid in the home and the community and hospital, discuss teaching strategies to overcome nursing practice challenges in the hospital setting, explore opportunities, strategies for community-based teaching. Topics and the speakers, so standardizing, individualizing, or both, by Patty Osborne Shafer, epilepsy nurse specialist and consultant from the United States of America. Hospital-based teaching from Grissel Crasto, advanced practice nurse, professor of nursing and consultant, Toronto, Canada. Strategies for community-based teaching, Richard Mwakanolo, Richard, from St. Francis Regional Referral Hospital, Morogoro, Regional-Ifakara, Tanzania. I'm going to stop sharing now, and we're going to play the video.
Seizure first aid, can we individualize it, standardize it, or both? Why should we teach seizure first aid? Well, seizures are common, or 10% of the people will have a seizure in their lifetime. And if you have repeated seizures, particularly long seizures, and seizure emergencies like status epilepticus, the morbidity and mortality is high. So we want everyone to be able to recognize seizures and their symptoms, to be able to respond appropriately and in a timely manner, and to be able to facilitate a person's recovery and get emergency help if needed. We want to help protect brains. As we're thinking about who should learn seizure first aid, I separate it into 2 groups, the healthcare professionals and lay people. So obviously people who are treating those with seizures, or epilepsy, absolutely, they need to know seizure first aid. And that's more than just the nurse. Yet, in what setting? Are we looking at only neurology and epilepsy units, or does that also mean emergency room, critical care units, and so on? But people can have a seizure anywhere at any time. So what about primary care, gynecologist, physical therapy, any of the other healthcare settings? So if we think of all of them, we get down to anyone and everyone should really learn seizure first aid. Now, we tend to focus a lot on first responders, but we don't want people to wait till the first responder arrives. We want to make sure people know what to do before they come. When we think about the lay public, obviously we focus first on people with epilepsy, their families, and their friends, and that's appropriate. And usually people with epilepsy and their families are leading that because not only do they need to learn it, but they need to be able to share it with their family, friends, and their kind of network of people. But there's people outside of them that come in contact with them. So that could be teachers, it could be daycare providers, residential people, employers, coworkers, and on and on. Now, in some cases, that's done by the person with epilepsy or their family. Um, but as a community, there needs to be education about many of these groups of people. And that's where many of the, maybe you as a nurse or the healthcare professionals, but also advocacy groups can come into play as teachers in educating larger community groups. There's no ideal time to teach. You need to look for that teachable moment and whenever you have that person available. So, for healthcare professionals, we can't assume that they've got this training in school or during their training. We need to look for that teachable moment, such as when they're hired for a job or new to a specific setting. And if that setting, cares for people with epilepsy, they need to know seizure first aid, and that would be an ideal time. But for larger groups of people, maybe it can be tied to other competencies they need, like CPR or infection control. So it can be done over repeated intervals. For people with epilepsy, families and caregivers, there's certain times along their journey with epilepsy. So at diagnosis is a perfect time, but that first visit might be hard to do everything that you need to do. So maybe a short follow-up right after that, either in person or live, needs to be done to make sure they're aware of what to look for and what to do. If a person has a change in seizures or their diagnosis change, are they aware of what to do for some of these new symptoms or new seizure types? What about if they have risky settings or scenarios? So they want to travel by plane or by bus or train. What would they do in those situations? Or a female who's going through adolescence and seizures start occurring around her menses, or the persons who are having seizures at night and they're alone. All those scenarios need to be addressed. When someone's seeing a new provider or going to a new practice, that provider should review what are your kind of seizures? What are you aware of? What do you know for seizure first aid? And don't assume that that's been done in the past. And if someone's having rescue therapies, make sure when that prescription is refilled or you relook at that seizure action plan, that again, the basic seizure first aid is reviewed. There are many ways that seizure first aid can be taught. Here's a few examples. So one-on-one teaching is obvious and that you can tailor that to the person's age, to their setting, to their seizure type. And that can be very helpful and doable as part of a clinic visit, maybe as a separate visit, so you can create a seizure action plan at the same time, or even in a virtual visit. Live settings can be good for groups. So, for example, you could do it at your healthcare setting, at a camp, at a support group, or even virtually over a webinar. Uh, the on demand, it can be easier for the learner because they can do it at their own pace, but often doesn't allow enough for tailoring. Yet a case-based approach or a simulation approach has much more ability to individualize to a certain setting or type of seizures. Keep in mind the use of videos, pamphlets, or handouts are great as adjuncts to any of these other methods, but when it's used by itself, then you don't know whether the person really understood it and it can't be tailored in that way. Think about the length of group teaching. There's no ideal length, but the longer you have it, the harder it is to retain, and you might lose motivation. I've been involved with 60 to 90-minute ones with a lot of interactive sessions, and that's worked well, just focusing on seizure recognition and first aid. Sometimes it's built into longer epilepsy education programs for 2 to 4 hours or so. There can be a number of obstacles. Is the person motivated? How can you enhance their motivation? Will the length of the program affect their motivation and willingness to participate? How much time does the educator have and how much time does the learner have? What's the cost? Is it free? Will health insurance cover it? Can a person get reimbursed? Do they have access to the technology needed or the travel if they need to be there in person? Regardless of the audience, there's some essential elements about what to teach. So we obviously want everybody to be able to recognize a seizure or the different symptoms. But when you're working with the lay public, be careful that we're not over medicalizing it and we're using plain language. For the common or basic steps of first aid, use something that'll be easy for people to remember, tying it to some key phrases. Just giving a list of to-do items is really hard to remember. You really want to make sure that you include staying with the person, timing it, and giving that information to someone who's recording events. What not to do. Don't assume that they know what not to do. A lot of people still think they should put something in the mouth. What should they do after the seizure? When and how do they call for help? Keep in mind the importance of teamwork. Regardless of setting, hopefully there's more than one person, so you want the team approach. What does that first person do? And if someone else comes along, what should that second person do? If it's a child involved, are there age appropriate ways they can help? And who do they call if an emergency is going on? If you're in a hospital setting, teamwork is also important. Again, first responder, second responder, recorder. You don't need a code team for this, but you need people to work together. If someone is going to be given rescue therapy, make sure the people involved know how to give it and they know to give it in a timely manner. We don't want people to wait to receive a prescribed rescue treatment. And everyone should know how to escalate care if it's needed. Most seizures end on their own and you do not need emergency help. But if it happens in the hospital and seizures aren't stopping, do you call a medical emergency? Do they end up needing critical care? What do you do? If it happens at home, how do they call for help? So there's a lot of different handouts that are available in different websites. Here's an example of one from the Epilepsy Society in UK that links the first aid steps to calm, cushion, and call. Very easy to remember. The Epilepsy Foundation in the United States uses Stay Safe Side, and then you can wrap the details around those words. The Epilepsy Alliance of America has this handout that's focused around seizure types. Epilepsy Action Australia also focuses around seizure types, but they also give some illustrations on how to turn someone on their side, cushion their head, etc. Does seizure first aid work? Well, in a pilot project that I was involved in, looking at results of a certification program we developed in the United States, we found that knowledge of seizures in first aid, as well as the self-efficacy or confidence in seizure first aid, increased as a result of participating in a 60 to 90-minute program. There was interactivity involved here. 177 people participated, but we got pre-post tests of 94 that were completed. So while this was adults and it ended up being primarily white females, we did find some significant improvements and very good satisfaction with the methods. There are other approaches I've seen that have looked at longer programs, but what we really need is more studies that will look at longer term outcomes and clinical aspects as well. So in closing, when teaching seizure first aid, include the 3 R's: recognize, respond, and recover. We want to help protect the brain. Remember that seizure first aid is a critical public health issue, and it's a very important self-management task. So as nurses, can we spread the word about seizure first aid and participate in teaching seizure first aid whenever possible? Remember, we do need to evaluate the different methods, but know that you can standardize seizure first aid, you can tailor it in some situations, and you can use a combination that works well too. Thank you very much.
Hi everyone, my name is Grissel Crasto. I'm a registered nurse and an advanced practice nurse in Toronto, Canada. Before I start my presentation, I'd like to acknowledge my privilege and offer gratitude for living on the traditional territory of many First Nations in Canada, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. I want to start off by asking you to reflect on some questions. How many of you have experienced having to transfer your patients to non-neuro nursing units because of a lack of beds on your neuroscience nursing units? And then once you've transferred the patient, how many of you have received calls from non-neuro nursing units trying to transfer their patients back to your unit as soon as possible? Well, this is not an isolated experience, because as neuroscience nurses, our specialty and the care that we provide to patients is very specialized. Non-neuro nursing units typically are hesitant to accept neuropatient admissions. So why is this the case? There are many reasons for it. Three main reasons: lack of knowledge, lack of experience, and lack of comfort. Nurses in non-neuro units and clinics may be unfamiliar with seizures. Generalized seizures are generally well known, but focal seizures may be more difficult to recognize. They may not know how to assess a seizure. Lack of experience with patients who have neurological symptoms could also be the case. Nurses may be slow to respond due to lack of knowledge on seizure assessments and how to conduct one. Unlike epilepsy monitoring units, specialized neuro units, or ICUs, nurses in non-neuro units may not have protocols for seizure management, and generally overall lack comfort with supporting these patients. In my recent role as an advanced practice nurse educator, I supported 7 departments in perioperative services, including pre-admission clinic, day surgery, preoperative care unit, post-anesthesia care unit, surgical procedure unit, endoscopy and cystoscopy units at Toronto Western Hospital. Toronto Western Hospital has a neurosciences program, so it would be perfectly normal to see patients with neurological disorders. One time we had an unusual coincidence of 3 different patients having seizures over the course of 6 weeks in one of our endoscopy and GI units. But this happened outside the procedural room. Just to give you some background, the endoscopists and the MDs are with the nurses in the procedural rooms. So if any clinical deterioration or emergency occurs outside the procedure rooms, based on hospital policies and protocols, nurses in these units are required to call a code blue, which is an emergency code for help. Since my office at the time was in another building, it took me about 2 minutes to run over to this endoscopy unit. When I arrived, I noticed that the staff was somewhat nervous and were looking for directions on what to do. I recognized in that moment that 50% of this staff was new, with less than 2 years of experience in the endoscopy unit, and some of the nurses were brand new novice nurses and nursing students. Because of their newness, many of these staff look towards the nursing leadership, including myself, for direction on what to do in a crisis. I debriefed with my team that morning after the first event, and I asked them for their thoughts on what went well, how they felt about their response to the patient having a seizure, and I wanted to highlight something really important. When doing a debrief, it's important to create a safe space for staff so that they can be honest and open. The environment of the debrief must be non-judgmental. This encourages staff to own what they don't know about a topic. And lastly, it's very important to request all the staff in the room to respect their colleagues when they share their vulnerabilities in the group. So what did the nurses share? Nurse 1 said, I was a little nervous because I had never seen a seizure before. In the moment, I wasn't sure how to care for this patient. Nurse 2 said, when the patient started hyperventilating and turned increasingly red in the face, I paused and wondered what was going on. My immediate instinct was to put an oxygen mask on, but I didn't recognize in the moment that the patient was seizing. Nurse 3 said, I wasn't sure how to respond, so I offered to call a code blue and ask someone to bring the crash cart while I was on the phone. I'm glad you were here to help us. Notice that there are some overlapping themes in knowledge and practice gaps in the experiences of these nurses, as we discussed in slide number 1. So how do we build capacity in our nurses to manage seizures? As nurses, we can't provide nursing interventions if we don't know what we're dealing with. So after the first seizure, staff expressed wanting to learn how to recognize seizures and how to respond to patients experiencing seizures. So I went ahead and provided in-services or education on seizures and the basics of seizure management. I also provided education on the importance of recognizing the early signs and symptoms of clinical deterioration. I highlighted the importance of paying attention to a patient's past medical history when nurses complete pre-procedure assessments in the perioperative areas. If you're in the inpatient setting, this can be done during the admission assessment. Generally, a history of seizures, epilepsy, brain injury, neurological conditions, and falls can be indicative of seizure risk in a patient population. Furthermore, after the COVID-19 pandemic, we know that neuroinflammation is one of the complications in patients experiencing long COVID. We know that inflammation in the brain could result in seizures. Therefore, it's important to train all our nurses in seizure recognition and management. Simulation-based nursing education is a popular approach used in various clinical areas to help nurses with the opportunity to practice their clinical and decision-making skills through real life and hands-on situational experiences. So on Friday mornings, we had a 1-hour window of protected time during which I conducted 3 simulations on how to recognize clinical deterioration, such as patients having seizures, cardiac arrest, and how to respond to violent patients. After every simulation, I continued to debrief with staff to hear about how they felt, what we did well, and what were some of the opportunities for improvement. Based on input, I would further review any knowledge gaps on clinical management, hospital policies, and practices. So, what do we do when we detect a patient having a seizure? It's important to maintain a patient's airway by positioning the patient to the side to avoid any aspiration. You want to call a code blue or whatever the equivalent of an emergency code is at your hospital setting. Page an MD, bring a code blue crash cart to the patient's side. You should try to loosen any gowns or clothing around the patient's neck to make sure that you're protecting the patient's airway. Protect the patient's head and, if applicable, intracranial electrodes from trauma. Monitor pulse oximetry and provide oxygen to maintain an oxygen saturation of greater than 92%. Do not forcefully hold a patient down. Do not force the suctioning device into the patient's mouth. Wait for the patient until their mouth is open and relaxed. And lastly, prepare the lorazepam IM injection to be delivered. So what are some preventative measures in seizure management? You must check the wall suction and oxygen at the start of a shift. Any side rails, whether it be a stretcher or a bed, should be up. Try to use pillows or blankets as padding to prevent any head injuries, and try to remove any hazards from the environment so that the patient does not harm themselves while seizing. In terms of falls preventions, it's important to review if the patient has a history of seizures or any other neurodiagnoses. And lastly, ensure that the height of the stretcher or the bed is always at the lowest. Something important I've learned in nursing is that your assessments are only as good as your documentation. Our rule of thumb is that if you didn't document something, it didn't happen. When documenting, you want to consider breaking it up into before, during, and after the seizure. When documenting on before the seizure, consider whether the seizure was witnessed or unwitnessed by yourself. If the patient had any warning signs such as auras, such as blurred vision, feeling of panic or déjà vu, a high-pitched scream, or an epigastric rise. During the seizure, did the patient sustain any injuries during the seizure? How long was the seizure? Were there any changes in their gaze or eye movements? What was their level of consciousness like? And a very important piece of documentation focuses on describing how the patient presents during the seizure. While you may not be able to correctly classify the seizure, this documentation on how the patient presents is key for providers to make an accurate diagnosis and will inform the patient's treatment plan. Some things to consider are Were there any repetitive movements such as lip smacking, chewing, muscle stiffening, tonic-clonic movements, drooling, gasping for her air, etc.? What was the patient like at the end of the seizures? After the seizure, consider if the patient's level of consciousness has returned. What are their vitals like? Did they experience nausea or vomiting or incontinence? And all these pieces of information must be accurately documented to provide excellent nursing care. This is it for my presentation. I'd like to thank the ILAE Nursing Section Committee for inviting me to speak today.
Hello, you are welcome. I am Richard A. Mwakanolo from Tanzania, holding Masters in Critical Care and Trauma. Today I'm going to present to you on the challenges for teaching seizure first aid in Tanzania. So you are kindly welcome. On the introduction, that the risk of premature death is actually increased 3 times in Africa, and that is due to lack of access to health facilities when patient falls into seizure. And in Africa, organic nature of seizure is acknowledged, but it also believed to have some supernatural causes, including demonic possession, witchcraft, ancestor calling, and others they believe it have a divine punishment. So in Tanzania, secondary school students consider seizure to be transmittable, and this belief is a major reason for school dropout due to discrimination and stigma to those children with epilepsy, and sometimes makes them not to be free to play with their fellows. And actually, seizure it accompanied with stigma. It is associated with some spiritual belief, but also with a mental disorder as a complication. And this all marks the importance of education regarding seizure, stroke, epilepsy. On teaching the 3 R's now, lack of knowledge increases the potential for inappropriate approach to the 3 R's to seizure candidates. And now here, nurses, they play a key role on educating this community, starting with the patients themselves, going to the parents, caregivers, and the community on how to respond when the patient come up with a seizure. And you know here, patient play as a primary person. They are very, very pivotal in disseminating of information regarding the concept of seizure to the family and also to the community. And this is seizure training, it can take place in elsewhere, especially most it is done in school, but also you can organize with the community leaders. It can be done in a community ground where they usually used to do their community meeting. You can use that place to conduct the 3 R teaching or seizure first aid techniques. Now, what are the challenges faced by people with epilepsy and families? I think the most one is the stigma and discrimination here in Tanzania and Africa. But because of the stigma and discrimination, epilepsy become as an hidden disorder, and because they take it as a caste and accompanied with so many spiritual aspects, that's why it become as a hidden disorder. But also lack of awareness, that's why education is a key part here. So also is a challenge, but also local and some spiritual belief become a challenge and affect those people with epilepsy. But also lack of resources where there are no enough funds to go to the communities and teach them about seizure and epilepsy. But also delay of treatment, of which later it become to to some potential diseases like mental health conditions, and also, as what I've said, this can be part of it. So what are the methods of teaching first aid techniques in community? The first one is assimilation, and the second one is watching video clip within the community. So you find on assimilation, someone acts as a seizure, and another person acts as a first aid provider over there. So through that, it makes it easier for the others to capture the concept. But also, you can put them into video, or you can have some video clips which narrate some techniques of attending a patient with seizure. And that videos can help them to understand, because there will be seeing and hearing, and that combining of the two aspects, it will help understanding. But also, we can do the awareness campaign through radio and TV programs. But also there are some demonstrations that can be done and games that help them to understand techniques of first aid techniques. But there are some postures and picture showing steps of which they can help them to understand also, of which also they can be accompanied with some narration. But you can prepare a session in which you put or you ask them question and they give answers, and also vice versa. And two, it will be a room for them also to ask a question and you respond. So also that is a technique of teaching. But also group discussion, you can prepare them in a small groups, and you give them different tasks of which they discuss. Later, one of the member from the small groups that you make, they present on what they've been discussing. But also exposure of learners to the facility, exposing them to where their seizure or epileptic patient, it can make also as a way or method of teaching them. So on conclusion, seizure first aid varies depending on the types of the seizure that person is experiencing. And you know, most in Africa, we associate seizure with some superstitions belief. And so most of them, they are treated by the witch doctor, and others they go to church where they find the diviners and they pray for them to be healed, of which become one of the major reasons for delay of treatment. But I think we must have some research, especially based on culture and custom. How do they affect their mindset? How do they affect their concept of seizure and the epilepsy? Research is very important to be done, and also to educate the community, about what is seizure and what is epilepsy, and think this will raise awareness to them and will help them on how to interpret or to view the condition. And this marks the end of my presentation, and this is my reference. I can say asanteni sana. Thank you for the listening.
I'd like to thank everyone for their presentations, and I'm just putting up the ILAE Nurses section for more information on joining the nursing section. You can register at this website, or you could use the QR code, or visit the ilae.org nursing section page. I'm going to now kind of prompt us into discussion. So if anyone has any questions or discussion points they'd like to bring up, so that we could have a little bit of discussion, question and answers to our speakers, that would be really great. I'm going to stop sharing and I'll ask for our panelists, Patty, Richard, and Grissel, to turn on their video and we can start having a bit of a chat. Does anyone have any questions? There's nothing in the Q&A box yet, so I might start with a question for Patty. This is a question I think we come across frequently in our kind of care settings, both from our patients and our carers, as well as the nurses in the hospital. When to escalate? Does every seizure need a code blue or a kind of an emergency room visit for someone that's have a seizure in the community?
Yeah, thanks so much for asking that, because it's something, regardless of what setting, people get scared when they first see it, or they get overwhelmed. So they rush to emergency care quicker than is needed. So regardless of setting, majority of seizures are going to end on their own. So you don't want to go and call for emergency help or call for a code right away. You want to be keeping the person safe and watching the person, and depending upon the environment, there's going to be other things to do. The difference is a couple different things. If you're in a community setting and you're far away from medical help and you don't know how long their seizure is, you may want to call for that ambulance or medical help sooner rather than later. So it's not a half hour before they come get to help you. So maybe they can get there sooner on it, and then you can refuse the care if you don't need it. If you're in a hospital setting, if it's a typical seizure, don't call for emergency help, because, a 30 to 60-second seizure will end on their own. If you're in an epilepsy monitoring unit and you're lowering drugs, it's a very different story. So I like to teach people to say, make sure when you instruct people, you instruct when to call, when to escalate, because it's, at least in my experience, it's not a given all the time.
Thanks, Patty. That's great. We've got some questions now coming through in the chat, which I think is excellent. I'm going to direct this next one towards you, Grissel. There's a comment from Alyssa Worley in regards to seizure first aid, and do you tend to include ways to reduce SUDEP in your discussions about seizure first aid?
So the seizure first aid that I was referring to drew from hospital policies in the setting that I taught it. So our hospital policy for an outpatient clinic, in the experience that I went through with the case study, was to call code blue, because that is the protocol of the hospital. It's a requirement for sort of outpatient clinics that that don't have the equipment or don't necessarily have someone to come attend to the patients immediately. So in those settings, I would recommend following your hospital's guidelines and policies. But I have to agree with what Patty said. If you are in a well-equipped area, if you are in an EMU, you follow all the protocols that were outlined. Because the setting that I taught in was to non-neuro nurses, and they are so very new to seizures and epilepsy in general, I stuck to the basics of seizure management and seizure first aid. Talking about SUDEP might overwhelm them, and it might be more advanced, and it might be a topic worth discussing with maybe specialized neuro nurses that are in specialized sort of wards. And the reason I say this is because the events that happen in outpatient clinics are often isolated and one-off. So the focus is always, what do you do in a situation, in a crisis? How do you respond? What are you mindful of? What are you doing in terms of providing care? What are you doing in terms of documentation, and sticking to that? If there's something that I would teach in this setting outside of SUDEP, it would be post-ictal violence, because there is that possibility for post-ictal violence. So just preparing folks to, just be aware of their setting and what to do in the case of post-ictal violence.
Yeah.
Thanks, Grissel. I think that's very important in that kind of setting. I think definitely post-ictal violence as well as SUDEP are important terms, but focusing on what your audience is a key feature, I think. So
Melissa,
the next
can I jump in on an important point on the SUDEP? Because that's just what Grissel is said is so important. But when you've got that opportunity, like if you're teaching patients and families and you're running it, why do I need to know? Why do I have to worry about the length of the seizure? That's a good opportunity. Or why do I have to worry about seizures at night? Because people die from seizures, you know, and SUDEP is higher with nocturnal seizures, et cetera. So that opening of addressing the SUDEP issue is great to address with a motivation, or if you have the opportunity to really kind of go safety, because it's not just what do I do with a seizure, but what do I do with the scenarios around the seizure?
Yeah, actually, I think it's an excellent point. Thanks, Patty. So the next question I think I've got for Richard, coming from Tony Kennedy. Is there a budget within the public health to support education for epilepsy in Tanzania to reduce the stigma?
Okay, thanks for the nice question. In Tanzania, and I think to most African countries, seizure is among of the neglected, epilepsy stroke seizure is among of the neglected diseases or conditions. So to say, there are no specific budgets. Like me, I am working in a referral hospital, but there's no any budget from the government that they are supporting us. So mostly we depend from non-government organization where they receive funds from donors as the ones who run education around the community and help those patients who are admitted to the hospital or they come to the hospital as outpatients. So that is a challenge here in Tanzania.
Thank you, Richard. I think it's important to kind of discuss the options around budgets and money and how we can kind of overcome the deficits that you encounter. So the next question I have, I'm going to ask you, Grissel, is at what point do you administer high flow oxygen in a hospital when a patient is having a seizure?
I would monitor the patient to see how they're doing on regular pulse oximetry. So if their oxygen saturation is not going up, we want it to stay in that 92% mark and above, if possible. If the patient's oxygen is not going up, then at that point in time, consider using high flow oxygen.
Excellent, thank you. Did anyone else have any kind of comments around the use of oxygen that kind of Grissel mentioned? Excellent. So the next question is, so nurses where they practice about epilepsy care in Africa. Okay, so I'm just, nurses where they can practice about epilepsy care in Africa, 85% of epileptics of Africans cannot get treatment reference. How would you manage this case? I think that's probably directed towards you, Richard, in the sense of like the access of care for people with epilepsy in Africa.
Okay, thank you for the question. Of course, most of patients, they come to the hospital. We don't have those programs of following them to the community, and if happen, it's not, not many times. So in Tanzania, in a education curriculum, we have epilepsy as a subject. So it's where nurses they learn. And we have some seminars, but they are not much because as what I said previous, as government, they are not taking epilepsy as a serious condition. So that's why in my presentation, I've said education and much research is needed because in Africa, we have not much put enough effort to deal with the condition epilepsy. Thank you.
Thank you, Richard. So my next question is going to be around there's quite a few questions in here. We'll do our very best to kind of answer them all. What is the next question is, if someone is diagnosed with epilepsy and hasn't had a seizure in a number of years, would you recommend calling an ambulance? And Patty, I think I might ask you to answer this question around kind of prolonged seizure freedom and when the ambulance should be called.
Okay, so thanks for that question. In my mind, I would, instructions for what to do would be to not call the ambulance. However, there's some caveats, all right? So if the person has a history in the past of having prolonged seizures, but they always run into troubles, even though they've gone a long period seizure-free, if they're out in the community, you might want to make sure that they get seen afterwards, because it's been so long. So something has changed, right? So then you might say, well, if you've always had long seizures and you haven't had anything for so long, you probably should get seen. And the general point would be, if it lasts more than a few minutes, have someone call and get you seen, because there's something else going on in that scenario. Because 9 times out of 10, there's really something else brewing. Now, so that's one side of it. The other side of it is that you're unlikely to have a breakthrough seizure like that if you've been through so long. So you probably have time to wait. And again, it depends on your past history, your type of seizures. So you really need to work with the epilepsy team now, and given your scenario, what's in your best interest. Does that make sense?
Yeah, I think it does, Patty. I think it's kind of assessing and kind of managing what to be able to make a decision there. So I think the next question I'm going to ask is for Richard. Have you tried using seizure action plans to teach patients and their families and caregivers to teach seizure first aid? If yes, how has it worked?
Of course, to the patient and the family, as they come to the unit, and here most of them they are managed at the psychiatric unit. So when they come, there are some programs over there where we teach them on how to deal with, or on steps on how to go with the seizure first aid. As what I said, we concentrate much to the patient because it's our first ambassador, and then to the family members. And I think it has been helping because somehow communities, they've started to understand about the seizure and all concept about first aid. Yes.
Thanks, Richard. The next question I have is for Grissel. This is more in the sense of how do you keep up with the kind of the new nurses, so the ever-rotating kind of introduction of new grads and new nurses and kind of skill mix within the setting of keeping up your education?
There's a couple of things I do. So I build it into the orientation for new nurses. We'll cover, again, we'll try to cover basics. We'll try to cover what we've seen in the past. And I just want to remind everybody that I was teaching in a non-neuro setting. So, again, you start with the basics in non-neuro settings, and then you build them up over time. It's always great to be able to include a, in-service on SUDAP or an in-service on non-epileptic PNES, like PNES type of seizures as well. And just the diversity of topics. So I would slowly build them up with doing in services repeatedly. For the skill mix, I think it's really helpful to do simulations every so often. So I do simulations 2 times a year, and because that's what I can handle, or that's what I could do in terms of my previous role. It was 7 departments, so that's quite a few areas to look over. So trying to do simulation learning at least 2 times a year is quite helpful, because then it gives nurses an opportunity to go in there, get in hands-on, to look at, you know, how a scenario went, to look at what your strengths were as a group, how everybody stepped up or chipped in, or, you know, did someone take notes? Did someone bring supplies? Did someone help, you know, provide oxygen to the patient? Did someone go get the medications ready? You know, what were the different roles? And really looking at debrief as an opportunity to help identify what went well, what didn't go so well, what we can do in the future. And I think this is a good way to get new nurses feel comfortable. They're often shy and they're often scared and afraid to get right in, but the simulation activity really gets them into, you know, the action of doing. And so that's always a good method that has worked for me in the past. And then, you know, you just couple that with consistent in-services throughout the year.
Excellent. Thanks, Grissel.
Melissa, can I ask you a question?
Sure, Patty.
So Grissel's talking about the non-neuro setting, which is so critical. But you in an epilepsy monitoring unit, so you've got new nurses coming along. And so what you do there might be different. So how do you time it, you know, educating the staff?
So I think in the setting, I always ideally like to say if I've got new nurses, especially new grads coming on, they wouldn't be directly kind of looking after people in the EMU, because the setting I do work in the EMU is kind of set within a neurosurgical kind of inpatient unit. Is the opportunity is to make sure they're aware of what the unit is, what the importance of it is, what their role will be in the sense of supporting the nurse within that may be looking after the patient, or the nurses within the ward that would be ideally looking after the patients. But also when they move beyond the kind of new grad setting, is to say, okay, is one-on-one orientation, you know, go through hands-on, what do you do with seizure? How are we going to manage this? As well as the kind of formal, more directed education. So like learning, teaching, written education. And then it's about shift to shift support, both from myself as well as the team leaders, the nursing unit manager and the educator, is to say, if they have a seizure, what are you going to do? You know, just being like at the beginning of the shift, I do a bit of one-on-one, you know, if they're having a seizure, what are your kind of steps? And just getting them to think about it in advance, so that if and when it does happen, they know that what they should be doing, as well as making sure that the rest of the team are supporting them as well, because it's not just about that one person looking after the patient, it's about the team of people looking after them within the nursing kind of setting.
Thank you.
Thanks, Patty. Actually, my next question is for you, Patty. I think we're going to run out of time and I'm not going to be able to get through all of the questions, but other than standardized public tools for seizure first aid that are available, are there any specific nursing curriculum for seizure response and the seizure first aid widely available?
Yeah. So that depends on your country. I know in the United States, the American Association of Neuroscience Nurses has guidelines for the care of people with epilepsy and seizures. And in there is going to curriculum on the seizure first aid. So that's available, and that's through AANN.org. I believe, and somebody can write this in from the UK, but I believe one of the UK organizations also has that. There are tools for giving rescue therapies and programs from the UK. I think it's through ESNA, Epilepsy Specialist Nurses Association. And so look at your neuroscience nursing organizations for that. I know Epilepsy Foundation in the United States has public health program, and particularly for school nurses on caring for students with seizures, as well as the general public. So schools are probably a good place to look, school nursing organizations, as well as neuroscience. And the ILAE will soon have this as we finish our competencies for nurses, and we'll be doing a curriculum for the first aid.
Thank you, Patty. I think that's important to make sure that we nurses are able to locate resources and curriculum for kind of basing their practice as a broad reference. So I'm just going to share my screen. I apologize. There's a series of questions that we're not going to be able to get through in answering in the Q&A box, but we're coming to the end of the webinar. So I wanted to take this opportunity to thank all of our speakers and make sure that thank everyone for joining, and the next webinar will be in October, and just put out a call to say we need you. So if you're interested in speaking or participating in the nursing section webinar or the development of the webinars, please reach out to the ILAE nurses at gmail.com, and we will be more than willing to have assistance and for your help in kind of generating these webinars to make more education for nurses on epilepsy and seizures around the world. And thank you.